Good evening and welcome to Doctors on Call. I'm Dr. Peter Nalin, professor and head of the Department of Family Medicine and Biobehavioral Health at the University of Minnesota Medical School, Duluth campus. I'm your host for our program tonight on upper extremity, shoulder, neck, and back problems. The success of this program is very dependent on you, the viewer, so please call in your questions tonight or send them in ahead of time to our email, ask@pbsnorth.org. The telephone numbers can be found at the bottom of your screen. Our panelists this evening include Dr. Joseph Bennert, a sports medicine specialist with Aspirus St. Luke's. Dr. Tolga Hanhan, a family physician with Aspirus Lakeview Two Harbors Clinic. And Dr. Brad Kuzel, an orthopedic surgeon with Essentia Health. Our medical students answering the phones tonight are Olivia Hoff from Rushford, Minnesota, Allison Pulst from Alexandria, Minnesota, and Ellie Tyne from Clara City, Minnesota. And now on to tonight's program, upper extremity, shoulder, neck, and back problems. And we have our first question already. Doctor, what are treatments for shoulder dislocations?
So it depends on a couple of factors. I think the age of the patient matters as well as their history. So as a rule, younger patients and those who've had a history of dislocations are more susceptible to recurrent dislocations. Shortly after the injury, the first goal is really just to give the shoulder some rest. So that may involve being in a sling and just letting things calm down. Oftentimes we'll start with a course of physical therapy, though for those who are at a higher risk of recurrence, it may be prudent to talk to a surgeon more quickly about possible surgical intervention.
Thank you. Dr. Hanhan, this question for you. What has changed regarding back strains and recommendations for bed rest?
Yeah, there was an era where people who hurt their back, and when we talk about back injuries, there's a lot of them, but the most common by far would be just straining those big back muscles. And it was just to simply lay around because that made you feel better, until you got better. However, that's really the last thing you want to do. It's kind of counterintuitive because when your back hurts, you're in a lot of pain. The last thing you want to do is start moving around, start walking, start doing all of the activities that you need to be doing in life. But really, that's the best thing that we need to do is just keep moving. We need to keep limber. If you think about the back anatomy, we've got these bones with these discs that are sandwiched in between them, and we just got to keep that moving even when you want to seize up and just relax. We know that people who are active heal faster and basically have a better recovery.
Thank you. Dr. Kuzel, what is a frozen shoulder and what can be done about it?
So frozen shoulders, it's a somewhat rare condition that can happen to patients, and I think usually the main reasons that they happen, one is trauma, and so patients can get a stiff shoulder after a traumatic injury, but sometimes they just happen without an injury. Patients who have diabetes or thyroid issues can have a higher chance of getting a frozen shoulder. And oftentimes they go undiagnosed for a while, where the patient will have this really stiff, really painful shoulder, and they'll see a lot of physicians and not really know exactly what's going on. The initial treatment of a frozen shoulder is always kind of like the back. We want to start moving it. And so if you see somebody and they are able to diagnose the condition, a lot of times we'll start with something like a corticosteroid injection, just a cortisone shot to decrease inflammation, and then start some physical therapy. And I think one of the most important things with a frozen shoulder is to reassure the patient that it won't last forever. No matter how they treat it, it will eventually go away. It will eventually resolve. And I think kind of relieving some of the anxiety related to it can also help a lot. As a surgeon, sometimes I'll see patients who've had this going on for 6 months. I've had a patient once that was going on for 2 years, which seems kind of on the far end of the spectrum. If it's been going on for over 6 months and you've tried therapy and you've tried cortisone shots, sometimes we'll do something called a manipulation, and it can be very effective pretty quickly. Another treatment is to do an arthroscopy where you use a scope to do a release. And then finally, there's one last option that's done under ultrasound guidance called hydrodilation. And I think if you look at studies, they all are pretty equivalent in terms of their efficacy. But the key thing, I think, is making the diagnosis, the correct diagnosis.
Thank you. Doctor, what is the connection between knee pain and a back problem?
So we know that everything in the body is interconnected, something we refer to as the kinetic chain, which means that problems in your ankle or knee can have upstream effects into the hip and low back. So if you have a trouble with your knee pain and it's changing your mechanics of how you walk or how you do stairs or just how you're moving about your daily life, that can have upstream effects where your back can start to hurt due to compensating for the knee.
Thank you, Dr. Bennett. Dr. Han, this question for you. What is cervical radiculopathy and how does it feel to the patient?
Yeah, so I think most people are familiar with the term sciatica, which is basically a nerve that may be getting pinched or undergoing some stress coming from your back and ending up in your leg. A cervical radiculopathy is essentially the same thing, but it's coming from your neck and then ending up in your hands. So it is uniformly unpleasant to people that have it, and it can be for any number of things. Most of us have got some type of arthritic change in our neck after about age 30 or so. And so just because of that, you might have kind of an area where it's hard for that nerve that leaves that neck to kind of exit without getting pinched by some bone. The same can happen if you have one of those discs that are starting to bulge out and it can pinch that nerve. So, and that the nerves from the neck go down and feed basically your whole hand. There's different nerves for different parts of the hand. And when you get a cervical radiculopathy, the word radiculopathy is Latin for radiating, and that's kind of what it feels like. It's kind of it can be a tingling or a lightning bolt sensation. It can be very uncomfortable. And so that's kind of how the hand and the neck are related. The good news is most people who get a cervical radiculopathy, if you don't have kind of a muscular problem associated with it, they tend to get better within 6 to 12 weeks or so, but it can be very uncomfortable in the meantime.
Thank you. Dr. Kuzel, this question's from a caller in Duluth. Judy wants to know, what are the best exercises for shoulder bursitis and impingement syndrome, and how long do these conditions take to heal?
That's a great question, and something I talk with my patients about routinely. So one of the most important things for shoulders is they like to move. So even if you have an injury, it's okay to let it rest for a few days and let things settle down. But then as soon as you can, start to try to move the shoulder. And simple movements like stretching it out on a table, walking up a wall, those are really effective ways to maintain or keep range of motion in the shoulder. For kind of specifically for bursitis or for impingement, I really like exercises that, again, kind of focus on motion, but also strength of the muscles in between the bones that are called the scapula or wing bones. Keeping those muscles strong and keeping the scapula open, just exercises like this are very effective for treating bursitis and impingement. And then there's a deep layer of muscles around the shoulder called the rotator cuff. And so exercises for strengthening the rotator cuff muscles are really important as well. So I'm sure you've seen the bands or using light free weights, 1 or 2 pounds. But really, shoulders like to move. And so if you have a sore shoulder, even if you think there's something torn in there, it still is very safe always to move your shoulder, an effective way to treat the pain.
Thank you. Dr. Bennett, a caller wants to know, how important is posture in preventing and managing some of these pains? And do you have any tips for improving posture?
Yeah, posture is super important for kind of everything we're talking about today, from the shoulder through the neck down to the back and out into the extremities. Getting back to what I was talking about earlier with the kinetic chain, we know that if one spot on that whole path is out of alignment or out of whack, that's going to cause problems throughout the whole system. So you really do want to work on posture. Unfortunately, our society is very screen focused, looking 6 to 12 inches in front of us a lot of the day. And that can really cause problems on the cervical spine, for example. And so giving breaks in your posture throughout the day to stare off into the distance, give those neck muscles a break is important. From a posture perspective, we know it really all starts in the core too. So getting to more of the lower back, you really want to have strong core muscles, you want to have strong gluteal muscles supporting your pelvis and your low back, because all of the rest of your movement is going to start from there.
Have the number of patients presenting with these screen issues continuing to increase or leveling off? Or?
I mean, screens have been a part of our life for long enough now that I think it's fairly stable on that front. But we definitely see conditions exclusively related to the advances in cell phones and personal computers compared to 10 or 20 years ago.
Thank you. Dr. Han, how do you, sorry, not that question. We did that one already. Pardon me. What makes the shoulder joint so dependent upon muscle strength?
Yeah, that's a great question. If you really think about the shoulder, Dr. Kuzel, of course, does all kinds of surgical interventions about it, but I actually think it's quite an amazing joint. If you think, what can we do with this arm? I mean, we can do, when it's healthy, we can do all kinds of movements. And so it's all muscle, right? I mean, we have other structures in there, but take away the muscle for a moment, and your arm would essentially fall off, right? So it's this ball and socket that exists, but it's really the muscle kind of holding your arm in place and working with all these mechanics that allow us to do all of these amazing things. I mean, compare the shoulder to the elbow or the knee, and it's much more muscular dependent.
Thank you. Dr. Kuzel, this question is about rotator cuff tear. And a caller from Duluth wants to know, can a rotator cuff tear be treated or replaced or improved without using anchors?
So that's a great question as well. And so we know that there's a lot of patients who have rotator cuff tears, even sizable ones who don't have a lot of pain. And there was a very large nationwide study that showed that patients treated non-operatively for rotator cuff repairs could be successful about 75% of the time. The key caveat to that study was that the patients had to believe that therapy could work. And so that may not be fully answering the question, but yes, rotator cuff tears can be treated non-operatively. What I'll say about the anchors is the anchors that we currently use are the best anchors that we've ever had. Most surgeons use anchors that are all suture. They're about 2.5 millimeters in diameter, so they're almost hard to even see on an MRI if you ever get an MRI after surgery. They really do very little damage to the shoulder. The suture material itself is nylon, and it's been used for decades. It's very safe, and so I don't think you have to worry about setting off metal detectors or things like that if you have a rotator cuff repair. There's always research being done, and so they're looking at biological augmentation, like how do we make the rotator cuff repair stronger? Because traditionally that's been the weak link, has been a patient's tissue and the quality of their tissue. And so there's a number of things that are being studied and looked at and even being done, but ultimately the rotator cuff repairs that we're doing now are again, the implants that we use are the best that we've ever had. And I've been doing rotator cuff repairs in practice for 12 years and in residency for 6 years before that. So
sometimes in medicine we use words that have other meanings. And when you're speaking to patients, how do you explain to them what is this anchor that's come up? What is an anchor?
Yeah, like one of the things I'll do is I'll show them a picture because it's a lot easier to understand, and so I'll pull up a picture of what the anchor looks like. But basically the rotator cuff, if normally it's kind of attached to the greater tuberosity or part of the ball or the humerus, And when it tears, the muscle kind of wants to pull it back. And so the muscle fibers naturally kind of pull the tendon back. And so it tries to heal on its own sometimes, but it's very hard with that muscle pulling back. And so what we do is we use anchors, and they're kind of like climbing anchors, if that helps. But it's just we'll put the anchors in the bone, and there'll be sutures coming out. So 4 sutures coming out of each individual anchor, and then pass those through the muscle and pull it back over. And that helps hold the tissue on the bone until it bonds and heals. And sometimes with my contractors, I'll tell them it's kind of like, you can't walk on the tiles for 24 hours. You have to wait for the grout to set. And the same is true for the body. Unfortunately, it's more like 24 to 26 weeks for full bonding when you do a rotator cuff repair. And so that doesn't mean you don't do anything during the recovery. We have a very active recovery. But what we really want when we do the repair is to bring that muscle back and get it to bond to that surface, to bond to the bone.
Thank you. Dr. Bennett, this question's about a healthy back. How might 1 mile of brisk walking each day be good for one's back?
Just in general, we know that staying healthier, staying active in general is good for our health. And so in that sense, we know walking has a lot of benefits from our cardiovascular perspective, helping to oxygenate the muscles that are supporting it. It can help in maintaining a healthy weight. And we know that being overweight or having obesity can put a lot of extra stress on the back and lead to further degeneration and arthritic changes as we age. So just in general, it's good from that perspective. Kind of like we were talking about with the shoulder too, we know that movement is good. And so we want to stay active, keep moving the back and training those muscles. Whereas you think when you go to a gym, you might do specific squats for your legs or curls for your biceps. The back muscles really get worked out by the day-to-day movement that we do throughout the day. They're constantly engaging at a microscopic level as opposed to in these large sudden bursts of energy. So things like walking are creating those micro movements that are training those muscles to function more effectively and really do their job more efficiently.
Thank you. Dr. Hanhan, this question also about the back, but specifically about the discs. Is it possible to, from a caller in Hayward, is it possible to have a disc surgically replaced, and how long would the recovery be?
Theoretically, yes, it could be replaced. I don't think there's a whole lot of that going on. And I'm not a spine surgeon, so I couldn't answer that question about how long it would take to recover from an artificial disc. But I can tell you for other kind of major back surgeries, like a fusion, might take 6 to 12 months to completely fuse kind of between 2 bones, which is a little bit more commonly done surgery.
Thank you. Dr. Kuzel, a question about rotator cuff surgery from a caller from Duluth. What can be done for tingling that goes down the arm, which seems to happen mostly at night?
Is it after a surgery?
After a rotator cuff surgery.
Okay. Yeah, to me that kind of sounds like something that may be, it may be that cervical radiculopathy that we were talking about earlier, when a patient has numbness and tingling that radiates down the arm. So kind of looking into that, there are some neck exercises that can be done that can help. I think thinking about how you're sleeping at night, how you're positioning your arm. I do have patients that sometimes don't do well with the sling, and I'll talk with them, and as long as they're not moving a lot at night, it's very reasonable to position your arm in a straight position. Typically, we can get numbness in our fingers when our arms are really bent up at night like this. We've all had this happen. And then you straighten your elbow, and then all of a sudden it feels a little bit better. And so just kind of positioning the arm, maybe having some pillows underneath it if you're sleeping in a recliner. I think things like that can help. And certainly sometimes people can have symptoms like that after surgery. Almost always they will just resolve over time.
Thank you. Dr. Bennett, this question is about a 72-year-old who's had a cortisone shot in the shoulder about 4 to 5 months ago, throbbing soreness from the shoulder to the elbow at the end of the day.
Okay.
Is this something that should be checked out by a doctor?
So I'm going to infer a little bit here that the throbbing has started more after the injection as opposed to predating it. Certainly if the injection had helped and they were getting relief and now we're 4 to 5 months later and that throbbing has returned, it would be reasonable to follow up with the physician who had provided that shot, as we know they last on average for about 3 months, so it may be time for a recurrence. The other piece to that too is there's multiple spots that a steroid shot can be given into the shoulder, and so it's possible that if the throbbing didn't resolve from that first shot but had predated it, that it may just not have been the right target, and again, follow-up would be appropriate to make sure that it's not coming from one of those other spots. That being said, assuming it is a new symptom that developed after the shot and it has been going on for 4 to 5 months, I would say yes, it is reasonable to follow up with likely the person who provided the shot to get an evaluation and see if it is a case of a reaction to the shot, or more likely if it's just another issue going on with the shoulder that happened to start around that same time.
Thank you. Dr. Hanhan, in contrast to fractures in the limbs, generally how are fractures in the back treated?
I think it probably depends on where in the back. The back is pretty complicated, and you can have a lot of different fractures. You can have, there's kind of a wing on the back of the backbones. Those, when they fracture, just kind of taking it easy is good enough. And but you can also have, there's some very important structures that go through the backbone, including the spinal cord. So if that spinal cord is threatened, that almost always needs surgery. And then some people can get what they call compression fractures, which is really kind of a crushing, so to speak, of the backbone, which is much more likely to happen with elderly age or osteoporosis. And those are also managed just kind of watching and waiting just to make sure that the nerves aren't affected.
Thank you. Dr. Kuzel, how is a dislocated shoulder put back in place?
Kind of depends a little bit on the dislocation. And one thing one little plug that I'll make is if somebody has a shoulder dislocation, the sooner you can reduce it, the easier it is. The longer you wait, the muscles start to spasm and contract, and it can get more challenging, and then oftentimes you're going to need sedation in the emergency department to reduce it. But there are a number of different maneuvers that you try, and it depends a little bit on some dislocations. Most dislocations are to the front, some are to the back. Sometimes there's fractures associated with dislocations, so the exact technique that you use depends a little bit on the type of dislocation.
Thank you. Dr. Bennett, this question about elbow bursitis, is there anything that can be done for elbow bursitis that occurred from trauma to that elbow?
So I'm assuming elbow bursitis referencing the olecranon bursa, or the bursa over the pointy part of the elbow there. There's not a lot of great options for it. We used to think about putting a needle in to the bursa and trying to drain some of that fluid out. There's been some research more recently that can actually introduce infection into the bursa. Similarly, there are surgical options that can be done to actually take the bursa out, but they carry with a risk of infection, as well as some difficulty with the skin overlying the bursa healing. So oftentimes we treat it very conservatively, which is using meds like Tylenol or NSAIDs over the counter for pain relief, and then putting compression to try to reduce the size of the bursa, and padding the elbow to try to prevent recurrence, because we know once it has enlarged and filled up with fluid, even if it goes away, it's at a higher risk of recurrence going forward.
Thank you. Dr. Kuzel, this question about screening for osteoporosis prior to shoulder surgery. In a postmenopausal woman, would a DEXA scan be ordered before shoulder surgery?
We typically won't, unless oftentimes we'll order DEXA scans when patients have had fragility fractures or fractures from just falling from standing height or injuries like that. Most of the treatments that we offer now, we can manage, even patients with osteoporosis, we can still do the treatments that we recommend. There are times, however, where if somebody looks like they have really severe osteoporosis, we'll make a different recommendation or a non-surgical recommendation.
Well, thank you very much. And I want to thank our panelists, Dr. Joseph Bennert, Dr. Tolga Hanhan, and Dr. Brad Kuzel, and our medical student volunteers, Olivia Hoff, Allison Pulst, and Ellie Tyne. Please join me again next week for a program on lower extremity knee, foot, and hip problems, when my panelists will be Dr. Taylor Puziak and Dr. Philip Thomas. Thank you for watching. Good night.